In this video, we shall explore the important factors that determine suitability for surgery in patients who have pancreatic cancer. This is one of the most important questions that needs to be addressed. Let's look at this cartoon. The liver is over here, the bile tube coming down, the gullet, stomach, a small bowel, and the pancreas with pancreas tube, and there is a tumor at the bottom end of the bile tube within the head of the pancreas. The typical symptoms from pancreatic cancer are pain, jaundice, nausea and vomiting, diarrhea, steatorrhea, weight loss, and pancreatitis. Pancreatic cancer is the leading cause of cancer-related deaths worldwide. Only about 10% patients will receive life-saving surgery, and the overall long-term survival is quite bleak. Patients have symptoms usually for months before they are diagnosed. The investigative pathway includes scans such as ultrasound, CT and MRI scan, as well as CT PET scan. An endoscopy may be required, endoscopic ultrasound, where a biopsy can be performed, as well as an ERCP where stents may be placed. Now, the most important question is whether surgery is possible or not, and the answer may be a definite yes, a definite no, or sometimes a maybe. And why is that? Two important factors determine whether or not patients get surgery. The first one is patient fitness. Now, you may think that patients are asleep when they are having surgery, and why should fitness of the patient be important? As pancreatic surgery is physiologically very demanding on the body and requires a minimum level of fitness that is determined by the surgical team looking after the patient. So this is not straightforward. Patients may be candidates for surgery straight away. They may not be candidates to start with because of loss of weight, jaundice, and other intercurrent illness that is reversible, but they may improve over time. And then there are patients who are not candidates for surgery at all, such as those bedbound or have severe intercurrent illness that cannot be improved. So what is the other main factor? And that is the tumor burden itself, the cancer in the pancreas itself. It may be low to moderate burden with no spread outside of the main tumor, that is stage 1 and 2. Or it could be a high tumor burden, but no metastatic spread, or with no metastatic spread, such as stage 3. And finally, there could be tumors that have spread outside of the main tumor, and they are stage 4 disease. It is much easier to discuss whether or not pancreatic tumor is resectable by explaining it with a diagram. So here is a rough sketch. This is the pancreas with a head, neck, body and tail of the pancreas. This is the liver. The liver has a bile tube coming out that traverses through the pancreas. This is the pancreas tube. There are lymph nodes around the head of the pancreas that I've drawn, and these are in red. These are the important blood vessels, the arteries, these two, and then the blue is the vein, the main portal vein. Let's look at this diagram to illustrate whether or not a tumor is removable from a surgeon's perspective. So here's the liver. The liver has a bile tube coming out, the main bile tube which traverses the pancreas. This is the pancreas with a head, neck, body and tail of the pancreas. This is a main artery that takes blood to the liver. This is another artery that supplies the gut. And this is the main vein, the portal vein, that takes blood back to the liver. Now, it is the association of the tumor. I've drawn a tumor over here, and it's the association of this tumor to the major blood vessels, the vein and the artery, that at least locally decide whether or not a tumor can be removed. If the tumor has spread to the liver, then these patients are not candidates for surgery at all. Now let's draw a tumor in close proximity to the blood vessels. Let's say the tumor is over here and it encircles the artery on the both sides. And the reason these tumors cannot be removed is that these arteries cannot be sacrificed. And by trying to remove the tumor, some of the tumor may be left behind that will be of no benefit at all to the patient. And this may be the case where a tumor involves both vein and artery, such as over here. And each patient's imaging is very carefully examined by experienced surgeons to determine whether or not an operation can be performed. If only the vein is involved, then in most instances, surgeons may be able to remove a section of the vein and then to reconstruct it. Just for reference sake, I have also drawn the T stage, the N stage and the M stage. T stage is the size of the tumor or its relationship with the main artery. And as you go down these stages, the prognosis becomes worse. And these are then amalgamated into stages 1, 2A, 2B, 3 and 4. Stages 1 and 2 may be removed with surgery. Stage 3 is perhaps advanced, and stage 4, surgery is not possible. We shall try and understand what surgical terms the surgeons typically use and what do they mean. Those tumors that can be removed, what I call take-outable, are resectable, and they are usually stage 1 and 2 disease. that the surgeons may be able to remove, and they are called borderline resectable stage 3 disease. And as I've discussed before, these tumors are adjacent to major blood vessels. And then there are those that just cannot be removed technically because they engulf the blood vessels such that clear removal of the tumor is not possible. And finally, surgery is not at all advisable currently for those with metastatic disease, that is stage 4 disease. So what conclusions can we draw from this? The patient fitness and tumor burden determine decision to operate. And patient fitness, thing that may change over time, i.e. patients may improve and then regain their fitness. When the tumor burden is low, upfront surgery is deployed. If tumor is adjacent to important blood vessels, then it could be borderline resectable, in which case the tumor may or may not come out with surgery, or it could be unremovable at all. Now this is where the role of chemotherapy before surgery, what's called neoadjuvant chemotherapy, with or without radiotherapy, comes into play. And in this instance, the chemotherapy is deployed so as to shrink the tumor and to kill off any stray tumor cells that have escaped into the body. The chemotherapy would be useful for patients with a high tumor burden, and as I said, those which are close to the major blood vessels. Finally, tumors that cannot be removed, palliative care is advised, and that may constitute chemotherapy where appropriate. I hope you found this useful. If you have any comments, please do share.